Maintenance of a normal posture and balance are adamant for daily activities. Especially, it is very important during the gait or walking process. Now, gait and standing and posture maintenance is a very complex science that involves a lot of players. There are a lot of somatosensory information, a lot of vestibular system which is involved, along with a lot of nervous system. Our today's topic are the gait and balance disorders. The gait and balance disorders are very common, especially in the old population or the elderly population. Specifically, it is stated that 1 out of every 4 person over the age of 80 has a fall episode per year. So it is very important to understand the normal physiology and anatomy involved in the gait process and also in the balance process, so that we can encounter these problems before they happen, and we can prevent falls in the elderly. This is very important because any fall in the elderly can lead to a lot of morbidity and mortality. And the major thing which we have is to prevent these episodes even before these occur. So let's start with the discussion of certain basics. What are the various factors which is involved in the maintenance of a normal gait and balance? Now, it is a multi-player process, maintenance of the posture and balance and walking, or maintenance of the gait. It involves various players such as the central nervous system, starting all the way up to the level of the brain and the spinal cord. Then the various sensory ganglion are involved, which help us in conveying the sensory information to the central nervous system, based on which we are able to adjust our position according to the environment. They're very important for the balance, for the joint sense or the position and the vibration sense. Along with that, the peripheral nervous system, which gives the feedback to the ganglion, they are very important. So apart from the central and the peripheral nervous system, the vestibular system is also a major player in the gait process, as it gives us a good feedback mechanism via internal ear, based on the position of our head according to the environment. Along with that, in the brain, along with the cerebrum, we have the cerebellum, which is very important in balance and coordination. We are going to see in the coming slides what are the various problems that can happen at various steps in this process that can lead to a gait and a balance disorder. So let's start off by classifying the disorders of gait. We broadly classify the gait disorders into the following types. Starts off with the cautious gait or the stiff-legged gait, Parkinsonism and a freezing gait. Parkinsonism is a major problem, especially in the elderly population. It is generally stated that over the age of 55, the prevalence of Parkinsonism is about 1%. So every 1 out of 100 person above the age of 55 has Parkinsonism, and it leads to a lot of problems along with the gait disorders. We are going to discuss Parkinsonism in slight detail in the coming slides. So there are frontal gait disorders, which are because of problem in the frontal lobe. Cerebellar gait ataxia, concerned with the problems in the cerebellum. Sensory ataxia, especially at the level of the spinal nerves or the spinal cord, the dorsal column medial lemniscus pathway, which we discussed in our lecture on the sensory system. And finally, the neuromuscular system, which involves the nerves, muscles, the neuromuscular tract, the neuromuscular junction at the level of the muscle and the nerve. So this is a broad classification of the disorders of gait. Let's go through them in a stepwise manner. Before them, let's discuss the etiology. Let's look at what are the major etiologies of gait disorders. The sensory deficits, they are the major causes of the disorders of gait, and out of 100, about 22 cases reported are of sensory deficits. These are generally related to the dorsal column medial lemniscus pathway problem or any problem in the peripheral ganglion or the peripheral nerves. Along with that, myelopathies at the level of the spinal cord, they are a major problem, especially in the elderly population. These can be because of any demyelinating diseases, or this can be cervical spondylosis, especially in the elderly population. Multiple infarcts or vascular issues also pose a threat at every level of the central nervous system, starting from the brain or the cerebellum or at the level of the spinal cord. Along with that, Parkinsonism is also one of the common causes of the disorders of gait. The gait presentation in Parkinsonism is considerably different as compared to the other types of gait disorders. We're going to go through what are the types of gait disorders in slight detail and what are the various features which on just looking at a person walking, we are able to conquer great information about that person's neurological or any other problem which has caused this gait disorder. There are certain other causes which are still unknown to us that cause the gait disorders, and medical science is looking in great detail into the what can go wrong at various levels. Certain other causes are the toxic causes. The most important one here is the alcohol intoxication, cerebellar degeneration, hydrocephalus. Psychogenic causes are also posing a major threat, which is considered under the umbrella of the somatoform disorder. Any type of anxiety or depression which manifests as a physical symptom, it can manifest as pain, and it can also manifest rarely as a gait disorder. So that is basically a diagnosis of exclusion after we have ruled out the other causes. All right, let's start with the cautious gait. Cautious gait, as the name implies, means someone who is very aware or very cautioned about his posture and his gait. This is generally a term which is used to describe elderly population above 75 or 80 years old, who are generally weak and frail, and they are very cautious about their movements, and they move with very slow, small steps, and they chase their center and move towards the center. So they are adamant on preventing falls. Now, this type of gait disorder is very common in the elderly population, as you must have seen old people who are walking very slow and very cautiously, taking very small strides. Along with that, the major reason of this type of gait of an elderly is that they want to prevent falls. And back of the mind, they have certain fear of falling. And this is also because of decreasing strength in their anti-gravity or the hip muscles. So their hip muscles are not able to support them walking fluently as in a normal person. So the important thing here is to look at this problem and address this issue with the person, because the people are not able to find out or understand that this might be a disorder. So what can we help to relieve this cautious gait? The basic thing is physical therapy. We can do certain physical therapy or certain physical exercises to increase the strength of their muscles. Along with the physical therapy, psychotherapy is also very important, that we have to counsel the patients to try to maintain posture and try to be confident and avoid this fear of falls. And this can be done if they have a certain confidence in their physical health. We can improve their nutritional status as well. So this cautious gait is generally not a type of a gait disorder. It is you can say that with progressive age, it is a type of a gait presentation which develops in the elderly population. Now, the proper gait disorder is a stiff leg gait. A stiff leg gait occurs when there is spasticity of the leg muscles. This is primarily of a sign of an upper motor neuron lesion. As we discussed in our lecture on the motor weaknesses, that upper motor neurons generally have an inhibitory effect on the lower motor neurons and all the reflexes. So whenever there is an upper motor neuron lesion, specifically either at the level of the brain or at the level of the upper cervical cord, it leads to disinhibition of the lower motor neurons. This leads to spasticity or spasm of the muscles, hypertonia, hyperreflexia, and this can present as problems in the gait. We classify them under the umbrella stiff leg gait. Now let's look at what can be the spinal causes of stiff left gait disorder. This can be cervical spondylosis. This is generally present in the elderly population at the level of the cervical spinal cord. There can be a lot of demyelinating diseases like multiple sclerosis or Guillain-Barré, and trauma can also present with spastic leg gait. All of these commonly lead to myelopathy, or problem in the muscle strength. This leads to a spastic and ataxic gait. How can we diagnose these? The major ones are to look at, we can do the laboratory test and imaging, especially at the level for diagnosing the demyelinating diseases. MRI is very helpful. And if it is presenting very early on in a young patient, and that patient has a family history of these disorders, for example, someone with Huntington's chorea or any other genetic disorder, the genetic testing is very important to find out the real abnormality, and can also help in counseling and the further evaluation. So these are the major spinal causes. Let's look at one example. In Caribbean and the North American population, generally there is a retrovirus human T cell lymphotrophic virus HTLV, which can present with a spastic paralysis. Now, this is a rare disorder, but this has been reported in the Caribbean population. So, certain types of infectious etiologies can also present with spastic paraparesis. We also know someone with typhoid, it can also present with spasm. So it is also important to look at the labs if we are not able to find out any abnormality on imaging or the genetic testing. Now let's look at a few cerebral causes of the stiff-legged gait disorders. The cerebral causes, along with the certain signs of the upper motor neuron lesion, they will also present with classical signs and symptoms like dysarthria or hemiparesis. Along with that, what are the various causes that can cause the cerebral disorder or a cerebral stiff leg gait? The major one is the stroke or the cerebral vascular accident, if there is obstruction to blood supply of any part of the brain. Along with that, multiple sclerosis like the demyelinating diseases, which along with which can present problems at any level of the central nervous system. They can present problems in the brain, in the spinal cord. Demyelination can be anywhere, and that's why the symptoms of multiple sclerosis are very different from any other etiology, and they are, as we classically say, they are spaced in time and space very broadly. It can be, and so in some person it can be an eye problem, in some person it can be a bladder problem, in some person it can be defecation problem. So that's why it is a slightly difficult disease to diagnose. And cerebral palsy, especially in the pediatric population, it can also cause a cerebral stiff leg gait or a spastic paresis at the level of the lower part of the body. So if these disorders are extreme enough, then these can lead to a condition which is called dystonia or altered tone. What are the classical presentations or the classical symptoms of dystonia? Someone with dystonia will present with an inversion of the feet because of the spasm of the feet. There will be a plantar flexion, and there will also be a torsion of the trunk. Now, these classical symptoms are present in someone who has extreme spasticity or higher upper motor neuron lesion. And these can progress as well. This can lead to this dystonia can lead to a sustained muscle contraction, which can also develop into repetitive twisting movement or twitching of the muscle. The arms or the legs might be twisted, and this leads to a certain posture in this patient, which is a classical posture of dystonia as shown in this diagram. You can see that the person has repeated twisting movements and he has sustained muscle contraction, and his arms and legs are presented, and the body is spastic or very rigid. And this is the classical presentation of someone with dystonia or a stiff leg gait. Now there is a rare entity which is classified as a stiff person syndrome. In this, what happens is there is lordosis of the lumbar spine, and there is loss of the normal curvature of the lumbar spine, and this leads to activation or the overactivation of the antagonist muscles on the opposite side of the body. And as a result of the overactivation, we have in stiff person syndrome someone which we call as a wooden posture. The antagonist muscles, they overactivate and leads to a wooden posture, as you can see here in someone with a very stiff or a very straight spine. This is the classical presentation of a stiff person syndrome. All right. Now let's talk briefly about Parkinsonism and freezing gait. Parkinsonism is a disorder because of destruction of the substantia nigra, dopamine-producing cells, as you know. So dopamine, as you know, you can relate to dopamine as someone, if you are driving a car, dopamine is the gas. It motivates, it drives you, it drives a person, it drives all the activities, it drives the movement. So dopamine is very important for the normal activity or the normal motivation and the normal movement of a person. Whenever there is destruction of the dopamine producing substantia nigra cells, there is a deficiency of dopamine. And the person, you can say that the car runs out of gas. So the person is unable to move. The classical signs and symptoms of someone with Parkinsonism is difficulty in starting or initiating movement. The person will stand and they will try to move and move and move, but they won't be able to start their gait. This is classically described as a freezing gait, that the person feels that he is frozen to the ground. And after a certain effort or certain time movement, they're slightly able to move. Whenever they start moving, they take very short steps located into the center, and this is classically called a fascinating gait. They move very slowly and move the chase as they are chasing down the center. They have a stoop posture, their head is slightly bent downwards. And then whenever they reach a point and they want to turn, they can't turn as a normal person can. They again stop there, then try to turn, and again after a while they are able to turn. This is because the major stimulus or the major neurotransmitter which is involved with the movement is dopamine. They are deficient of this neurotransmitter. Their car has run out of the gas basically, so they're just trying to move that with any other way. There are a lot of drugs which are used to treat Parkinsonism, which is a separate topic. You will be discussing it in great detail in the nervous system lectures. The classical signs and symptoms along with the fascinating gait are the pill-rolling tremors, the bradykinesia or the rigidity or the cogwheel rigidity, which we classically say. It is a very unfortunate disorder. There is no cure for that, and we are just trying to give symptomatic treatment. And there are a lot of types of drugs like the levodopa, carbidopa, or other type of drugs which are used to treat Parkinsonism. Along with Parkinsonism, certain other disorders that can present with the freezing gait or slowness of the movements. Classically, some types of supranuclear palsy can present with the freezing gait. Multiple system atrophy is a disease which mimics the Parkinsonism and can present as a freezing gait. And certain corticobasal degeneration disorders, and with their degeneration at the basal level of the cortex, they can also present as slowness or the freezing gait. Now, on the other spectrum, we have hyperkinetic movement disorders, classically someone with Huntington's disease. As you know, Huntington's disease is basically because of a CAG repeat or a CAG repeat. It is a trinucleotide repeat expansion disorder, and it shows anticipation, which says that with every coming generation, the disease severity increases and the disease presents at an early age. It is an autosomal dominant disorder, so anyone with Huntington's, whenever he or she has offspring, they are very likely to have Huntington's chorea. So these patients have a very tough life because along with the movement disorder, there are a lot of other things which are going on. They are generally very depressed. The movement disorder in this patient is a hyperactive disorder, as you know, that they present with certain violent and jerky movements of the hand. So whenever you see someone with Huntington's walking, it is like someone who is just dancing because their hands and feet are shaking whenever they are walking. And it is classically that presentation of hands and feet movement is called chorea or ethitosis. And that gait certainly is basically, if you see someone walking in with Huntington's with the hands and feet moving all over the place, it just seems like someone who is just dancing around. So it is a very unfortunate disease. There is no cure for it. All we have is symptomatic treatment, and these patients generally die of commonly they attempt suicide, and because it is very difficult to live with this disease, and they majorly die because either of they kill themselves or they are certain other types of lymphomas which can present earlier on in these patients. Along with that, there is a condition called tardive dyskinesia, which is also a hyperkinetic movement disorder. It is generally side effect of antipsychotic drugs in which there are various twisting and writhing movements of the arms and the feet someone who is taking the antipsychotics over a long period of time. So that can also present as a hyperkinetic or a jerky movement disorders. These are the major ones, which are the first part concerns with the freezing disorders or the Parkinsonism, and the latter part concerns with the hyperkinetic disorders. Let's talk about Parkinsonism in slight more detail. What are the other signs and symptoms along with the classical ones? The patient with Parkinsonism can have an axial stiffness. He can have postural instability. I have told you that they majorly present with their head bent down because they're looking at the ground. They are unable to appreciate their feet very normally, and they are just chasing their center to avoid falling to either side. The classical gait is called a shuffling or a fascinating gait with very small steps, and they have a very large incidence of falls, especially in very advanced Parkinsonism. So, and that is a major risk factor for morbidity or mortality in these patients because these patients are generally very old, and if they have a long-standing history of Parkinsonism and they have some fall, that can lead to major morbidity and mortality. So it is important to do physical therapy in these patients and try to just control the disease as much as we can. Now let's talk about certain frontal gait disorders. These are the disorders which are concerned because of any pathology in the frontal lobes, primarily in the premotor or the motor cortex. And these are basically upper motor neuron lesions in which corticospinal tracts are impaired. So these have classical presentations as hemiparesis, along with the problems in the arms or the legs. Persons with these gait disorders, someone walking in with this upper motor neuron lesion, you'll see that their arm will be very spastic or paralytic, and they will be holding their arms like these. And specifically, they'll try to move with a wide based gait to avoid the center and avoid falling. Along with that, the other symptoms are shuffling while walking. They can also have a freezing gait while with imbalance. This is very rare, but they can also present if there is a loss of a lot of motor tone or strength in their muscles. These patients can also have a freezing gait with imbalance. There will be signs of higher cerebral dysfunction like dysarthria and hemiparesis. Along with that, if the brainstem is also involved, there might be cross lesions involving the cranial nerves. They present with a wide base for support because the lower hip muscles are not able to support the movement in a straight line. That's why they present with a wide base support. Their legs basically move like this, outwards and inwards with every movement. They have a short stride. They can shuffle along the floor if their leg has a lot of weakness and the legs don't have enough power to lift it off the ground, then they can also shuffle along the floor. And they might have difficulty with the starting and turning, just like someone with Parkinsonism. That's why these type of starting and freezing problems, we term that under the umbrella which is called slipping clutch syndrome or a lower body Parkinsonism. The people with the frontal lobe lesion who have a problem in initiating movements and difficulty with starting and turning, that is basically termed under the umbrella of lower body Parkinsonism, as if these patients have Parkinsonism like problems in initiating movement and in turning movements. Along with that, these symptoms can present in any combination. Someone might just shuffle, someone might just have signs of higher cerebral dysfunction. If there is a lot of problem with the lower muscle strength, then they can also just shuffle along the floor and they will have very short strides. Let's talk about cerebellar gait problems called cerebellar gait ataxia. What are the various causes? What are the various types of lesions in cerebellum that can cause ataxic problems? The most important or the most common ones are the cerebrovascular accidents or the stroke, any interruption of the blood supply of the cerebellum, along with that any trauma to the cerebellum, any tumor that invaginates the cerebellum and leads to their presentation, atrophy of the cerebellum in certain long-standing metabolic disorders or because of any other cause, and then cerebellar degeneration with passing age. It is also a cause of cerebellar gait ataxia. And then certain genetic diseases such as the Fragile X mutation or Fragile X syndrome, which also presents with mental retardation, that can also cause ataxic problems at the level of the cerebellum. How do we diagnose it? The classical way to diagnose a cerebellar problem is imaging, especially MRI. Here you can see in these MRIs, the cerebellar is reduced, and this is classically an MRI of the cerebellar degeneration, very small amount of cerebellar tissue, and it is replaced by the fluid around it. Here again, this is a slide starting of the degeneration of the cerebellum here, and there is fluid all around it. So MRI or imaging is the major way to diagnose cerebellar problems. Now let's talk about what are the various sensory problems that can lead to ataxic gait. The major ones involved are the problems at the level of the peripheral nerves or the peripheral ganglion or the dorsocolumn medial lemniscus pathway. Now the dorsocolumn medial lemniscus pathway basically is concerned with the proprioception, vibration, 2-point discrimination, joint position. So all of them will be impaired if we have a problem with this dorsocolumn pathway, and they can present with sensory ataxia. Sensory ataxia means that the person who has this problem, he won't be able to judge the ground appropriately, and because of the difficult problem with the feedback from the sensory system. So they can have a falling episode because of inability to correctly judge the relative position of their feet according to the ground, as a proprioception problem or a joint sense problem. Classical diseases which can present with sensory ataxia is neurosyphilis, tertiary neurosyphilis, which presents with the diabetic neurosyphilis. It has degeneration of the dorsal column and the spinal cord problems. And this is a spirochete infection. We have antibiotics to treat them. Along with that, vitamin B12 deficiency can present or mimic the dorsal column medial lemniscus pathway problems. And the classical signs and symptoms that I just told you are because of the large fiber sensory loss, which convey the dorsocolumn tracts. What are the sensations they convey? They convey the vibration sensation, the position, 2-point discrimination sensation. So vibration sense will be diminished on examination with the tuning fork. There will be an imbalance because of inability to classically judge their position relative to the ground. They can have disturbance in proprioception. And then these patients basically to get rid of these vibration and other problems, they use the other senses like vision and vestibular system to travel and walk. So if they have any problem with the vision because of less illumination or less lighting or impairment in the vestibular problem, this can compound their problem. So classical test to diagnose this sensory problem or the dorsal column problem is a Romberg test, in which we ask the person to stand with both the feet closed and then look straight and then close their eyes and keep on standing. If after closing their eyes they start swaying to either side, this means that they have a dorsal column problem, or because that is a positive Romberg test, because their eyes or vision were compensating for the loss of this sensory input. And when you have cut off the eyes or the vision and their sensory input has been completely cut off and they are unable to appreciate the ground or their relative position to the ground. And they can also have a postural loss afterwards. They can present with a hunched back as well in long-standing problems. Treatment, if we have a vitamin B12 problem, we just replace the vitamin B12 therapy. If we have vitamin E deficiency, we replace the vitamin E. If we have someone with neurosyphilis, then there are penicillin antibiotics to treat the neurosyphilis. And it majorly depends on what is causing the sensory ataxia. Certain neuromuscular disorders can also present with gait problems. We discussed the neuromuscular disorders in previous lectures. The myopathies or problems at the neuromuscular junction, like the Lambert-Eaton myasthenic syndrome or myasthenia gravis, or this can be problems at the peripheral nerve system as well. What can be the various signs and symptoms? There will be sensory imbalances because of impairment of the sensory input. If it is exclusively a muscular problem, that they might present with myopathy or muscle weakness. There might be muscular dystrophy, like in Duchenne muscular dystrophy. The muscle is totally replaced by the fat, infiltrating fat. It is completely destroyed. These problems generally present as proximal muscle weakness loss. So there will be problems at the level of the hip girdle, or the weakness at the level of the hip girdle or the shoulder girdle. These can be because of a neuromuscular disease, or because it can be a side effect of any drug, like a statin-induced myopathy, which can present as a proximal myopathy. So with proximal muscle weakness, they're unable to maintain their posture and they have a higher degree of propensity to fall. And they also have, because of weakening of the muscles, they have gait disorders. And they can either present with a cautious gait or have a variable variety of gait disorders. Now let's look at certain toxic and metabolic disorders. The major player here is the alcohol. Alcohol is the most common cause of acute intoxication, and it is the most common cause of acute falls, especially in the Western population, where there's alcohol intoxication is very, people take alcohols in large quantities, and it can also present either because of an acute increase in the alcohol level in the blood, and because alcohol damages the cerebellum. So the person presenting with an alcohol intoxication, he just walks like someone who has a cerebellar gait ataxia. Like they have a wide base gait and they sway from side to side. And because, and with the increasing level of alcohol in the body, their consciousness or their ability to maintain their posture generally fades away, and they present with a fall. And with this fall, they can present with a large morbidity or mortality with various types of fractures as well. Along with alcohol, certain types of drugs or medications, especially the sedatives, they can present with the toxic and on the toxic when the toxic levels are reached, they can present with falls or gait disorders. Certain metabolic disturbances, especially the hypernatremia or the hyponatremia with altered consciousness or stupor, can present with gait disorders. These are generally the chronic toxicity of these things that can lead to an impaired motor function and which presents with falls in this patient or the impaired gait. The symptoms are just, as I talked before in the previous slide, there is a disequilibrium of the status quo or the static disequilibrium. A person who is just walking normally, he just can't equilibrate both sides or the both types of forces acting on him. And that's why, because of this disequilibrium, there is an increased propensity to fall. In someone with a metabolic disorder like hepatic NCAF or chronic renal failure, they can present with flutters or asterixes, which are basically altered movements of the hands, just like that. These are classically a sign when you ask the patient to move your hands front and keep it like this. In a patient with hepatic NCAF, these patients have these kind of movements of the hands. This is called asterixes. And just like here, this is also classified as a myoclonus. And these are generally present in someone with long-standing chronic renal failure because of uremia or someone with hepatic failure or hepatic NCAF. So these signs and symptoms are very helpful to identify the underlying cause of toxic and metabolic disorders. And these can present with stupor, unconsciousness, and can also present with stumbling gait or a fall. And finally, the last type of gait disorders are which we classify under the umbrella called the psychogenic gait disorders. As the term implies, the psychogenic gait disorder is basically a psychiatric disease which is presenting with a gait disorder. This is not very common, but somatoform disorders which generally present with any physical symptoms like pain or any other abnormality or weakness, they rarely present as gait disorders. What can be the underlying psychological issue? Majorly the anxiety. If someone who has extreme anxiety, or someone who is extremely depressed, or someone who has just a phobia of walking. There are very rare cases of someone who has classical phobia of just walking or moving. So these kind of patients are the ones in which they have either a freezing gait or they move with certain cautious type of gaits or various presentations of the gait disorders. And when you investigate these patients and are not able to find out any organic lesion along the certain central nervous system or any vestibular problem, and then when you do a psychiatric exam on these patients, you can very easily find out the cause of the underlying problem. And most of the cases, it is either anxiety or depression. Someone with depression, they, along with the gait disorders, they will have a classical primary slowness of movements, very slow, purposeless movements, which is we call term as the psychomotor retardation. There is no purpose to the movement. They don't know where they are going. They're very slow. They're very slow to react to your questions. And all the classical signs and symptoms of depression will be there when you screen these patients. And the lack of purpose is what we call as the purposeless movements. So psychogenic disorders are the ones which complete our discussion of the various types of gait disorders. The major one is the Parkinsonism, and other types are the various have varied presentations. Now, in the last part of this lecture, let's talk briefly about what is balance. Balance is basically defined as the equilibrium. Balance is the ability of the body to maintain equilibrium. By equilibrium, we mean that the body tries to counter the opposing forces or the physical forces and tries to maintain the equilibrium, which leads to a balance or a normal posture, which is then helpful in a normal movement. What are the various important players in maintaining our balance, and what can be the disorders of these problems at various levels? The major ones are the following. Cerebellum is very much involved in maintaining balanced posture. Along with that, the vestibular system, which moves all the way from your inner ear all the way up to the cerebral level is involved. Then the somatosensory system, which gives us a good feedback of our periphery via feedback neurons, the peripheral nerves or the ganglions or the dorsal column, spinothalamic tract. And at the level of the brain, the cerebrum, the somatosensory cortex is very much involved. So all of these players are the ones which are involved in maintaining balance, and disorder of any one of them can lead to a disorder of balance. Let's look at them briefly. With the cerebellar problem leading to a balance, it is just like the same as we talked about in the gait problem, which is classified as a cerebellar ataxia. It can lead to a fall. The type of a cerebellar gait is someone who is swinging from side to side, who is not very much aware of his ground, and he's just trying to compensate by moving his body to the other side and his legs to the one side. Neurodegenerative, this is also termed as a neurodegenerative ataxia in someone with cerebellar degeneration. If it is related to a cerebellar atrophy related to the age, then that can be classified as a neurodegenerative problem. And along with that, if this problem persists for a long time, that can lead to a loss of ambulation in these patients. So cerebellar ataxia can present either as a problem with the gait or either as a problem of a balance, because cerebellum is a major player in maintaining our posture and gait, along with the vestibular system and the higher peduncle cerebral hemispheres. The balance disorders can also be because of vestibular causes. The vestibular system is the one which encompasses all the way from the inner ear to the level of the cerebral hemispheres. Now, whenever we have a vestibular problem, then along with the balance disorders, the other signs and symptoms which will be present are vertigo, which is an illusion of the movement, nystagmus, which is an involuntary movement of the eyes, and along with that, there will be an impaired standing balance. So if we have these accompanying signs and symptoms with the balance disorder, then this traces it to a problem with the inner ear or the vestibular system, and then we have to investigate that accordingly. Similarly, at the high levels, at the level of the cerebral hemispheres, we can have cerebral disequilibrium, and this raises very much increases the risk of falls, and this is because the cerebrum might be impaired, or the person might have altered consciousness because of certain sedatives, if they are taking certain sleeping pills, or because of certain drugs for any psychiatric problems which have a sedative side effect. This can lead to a disorder of the balance. Or someone who has just developed dementia because of increasing age, or who is delirious because of any other medical issue, they can also present with higher level cerebral disorder of balance. So what happens when we have a balance disorder? When a person is unable to balance his or her body, they can lead to falls. And a fall is something which we really fear in someone, especially in an adult population, because it is a major cause of morbidity and mortality in adult population. If someone is not able to walk properly and unable to maintain their balance, they have a higher propensity to fall. Let's look at the various important types of fall patterns, and which give us good information about the underlying pathology. A fall can either be a drop attack or a collapsing fall. It can also be a toppling fall, or a fall due to a freezing of the gait. Or it can be a fall which is related to a sensory problem or sensory loss. Or the fall might just only be because of weakness and frailty. The lower legs muscles or the hip muscles are just unable to bear the strength of the body, and they lead to a weakness and frailty. What happens when we just drop attack or have a collapsing fall? This is majorly because of there is orthostatic hypotension. If someone who has been taking antihypertensive drugs, or who has just is just hypovolemic because of any other problem, they can just stand and fall down, as we talked about in orthostatic hypotension. Now, one important thing to remember in dropping attack or a collapsing fall is, if normally these patients retain their consciousness, they don't have altered consciousness, they fall down, they get up, and they are fine. But if the patient presents with a falling episode along with altered consciousness, then this might either be a syncope episode or might be a seizure episode, and then we have to investigate them very carefully, especially if this is a repetitive problem. If someone who presents with a repetitive falls, orthostatic hypotension, or someone who has a colloidal cyst in a ventricle, they might present with a fall in a one-off time, and when we just look at them, these go away with time. But if someone presents with repetitive falls in a short period of time, or someone who has altered consciousness along with the fall, then these are the major risk factors or the major danger signs which we have to investigate to rule out any underlying serious pathology. A colloidal cyst might be just a small cyst at the level of the ventricles, which just temporarily stops the flow of the cerebrospinal fluid, and that can present as a dropping attack or a collapsing fall. Or certain vascular risk factors like the transient ischemic attacks at the level of the cerebral hemispheres, they can also present with a collapsing fall. And these patients just stand, they are walking or they are standing and just they drop down to the ground, and then in the next minute they're just up and normal. So, what are the toppling falls and what are the risk factors for the toppling falls? Toppling falls is someone who's just moving in a straight line and they have a propensity to fall either to one side or forwards or a backward side. And the propensity to fall in either direction gives us a good idea of an underlying pathology. For example, in someone with a cerebellar lesion, they have a propensity to sway or fall towards the side of the lesion. So a person who has a left-sided cerebellar hemisphere problem, they're moving in a straight line and they're just swaying and start to fall to the left side. Someone with a lesion of the vestibular system, they have a lateral problem. They can sway from right to left and they have a propensity to fall on either side way. In certain conditions which are related or closely related to Parkinsonism, which we call this progressive supranuclear palsy, the person's body just keeps on moving and they have a propensity to fall backwards. Like the body is moving ahead and the head moves backwards, and they have a propensity of just moving very normally and they have a propensity of falling in the backward direction. That happens in supranuclear palsies. And along with in Parkinsonism, people have a propensity to fall. Now, this can either be because of a freezing gait problem, someone who's just walking and freezes or unable to turn during a normal walk in a person with Parkinsonism, or someone who has a problem in initiating the gait. And they can also have certain fall patterns like the supranuclear palsy, progressive supranuclear palsy people. They can have a propensity to fall backwards because their body is unable to support the balance or equilibrium. So these are certain types of toppling falls. Falls due to gait freezing is classical one is Parkinsonism, we just talked about in the previous lecture. And this gait freezing is basically a term which is used in difficulty in starting the movement. The Parkinsonism people, they feel that their feet are stuck to the ground and they're unable to initiate the movement. This classical term is used for generally in patients with suffering from Parkinsonism. Now let's talk about the falls which are related to the sensory loss. And with the sensory loss, the feedback mechanism of the sensory system from the peripheral nerves to the ganglion to the dorsal column and the medial lemniscus pathway, this is generally impaired. So the persons have general impaired vibration or proprioception, impaired ability of their position relative to the ground. So this can present along with the vestibular deficits as well if they are involvement of the vestibular nerves. This can generally present as a somatosensory deficit. And these patients basically rely on their other types of somatosenses to compensate for this vibration loss or the proprioception loss. Specifically, this sense of sight is very important to them, and proper illumination is very important for them to walk in a straight line because that vision is compensating for the other problems, somatosensory deficits. So if these people walk into a room with poor illumination, or if you ask them to just walk in a straight line with their eyes closed, they have a very high propensity to fall because that compensation of the vision is taken off, and then they have no feedback from their surroundings as to where they are positioned according to their ground. That's why any visual deficits can also present with a higher propensity to fall in these patients. And if along with the proprioception, there is a deficiency in joint position, if there is a dorsal column problem, and there is also a vibration sense problem, which is very much appreciable with the help of a tuning fork test. So all the large fiber problems, the joint proprioception, vibration, two-point discrimination, these are generally impaired if we have a dorsal column problem. These are generally classified under an umbrella of somatosensory deficits. And finally, someone might just be too weak and frail to walk. If they are very old, someone in their 90s, if they have certain problems in their muscles, the muscles are just unable to bear the strength of the weight of the person. And the only solution we have for them is the resistance strength training or the weight training to just make their hip girdle muscles strong so that they can bear the balance and bear the weight of the person when they are standing or walking to avoid the falls. What are the various important risk factors which can present as falls? These are termed in descending order of their occurrence. The number one is the weakness and the frailty. Just the muscles are too weak to support the person, or there are certain balance deficits, either because of cerebellar problem or any other problems. There are certain gait disorders. Someone who has a gait disorder, because of any reasons, as we talked about at the start of the lecture, they have a higher propensity of falling. If we have visual deficits, we are unable to appreciate where are certain areas of the vision, then we have a propensity to fall because of that problem. If someone has limited mobility because of any injury, or if they have a cast here, then they also, because they are unable to balance their body properly, they also have a propensity to fall. And finally, someone with a cognitive impairment who just has higher cerebral dysfunction and they're unable to appreciate the coordinated movement, and they lack the coordination of the various systems involved in maintaining the balance or the posture or walking. They are unable to have that cognitive ability. They have a very high propensity to fall, and they also have present with an impaired functional status, and they are not able to carry out their activities of the daily life. So what can we do to either reduce the occurrence of these falls or treat the conditions? Now, treatment is basically supportive. If someone presents with a fall episode or they have a broken bone or anything like that, then you have to fix that. But our major concern here is to prevent the falls. The prevention is the best policy here. We try to do as much as we can depending on the individual case. How can we prevent the falls? Because if once the person falls, then there can be a multitude of problems, and there can be a major cause of mortality or morbidity in these patients. So what are the various options we have to prevent the falls? We can have certain pharmacotherapy. For example, in someone with Parkinsonism, we use the various types of drugs to control the signs and symptoms and the progression of the disease. Or someone with Huntington's disease, we have certain drugs which are not curative, which are basically to increase the survival and to improve the various symptoms. Or we can basically, if the problem with the balance or gait disorder is because of any intervention or because of any drugs the patient is taking, like the anticholinergic drugs in elderly population or certain sedatives or certain antipsychotic drugs, then we can do something to either reduce the dosage of these drugs or altogether replace the drug with someone which has no sedative side effects, especially in an elderly population or someone who is just living alone and and there is no one to take care of them. Lifestyle modifications like better nutrition, controlling the weight, controlling the cognition, exercising regularly. Along with that, weight training is very important, which is helpful in the rehabilitative intervention, especially of the pelvic girdle muscles or the hip muscles. Someone who has weakness of these muscles or a neuromuscular weakness, they can have certain physiotherapy exercises to increase the strength of this pelvic girdle or the hip muscles or the anti-gravity muscles, which are the major muscles involved in maintaining the posture. These can lead to a reduction in the occurrence of the falls, and especially high intensity resistance strength with higher weights, slowly progressive increase in the weight, they can lead to an increase in the muscle strength and muscle bulk. And over a period of time, these are very helpful in avoiding the falls and increasing the strength of the muscle, which is especially involved in maintaining the posture and balance. And finally, for patients with Parkinsonism, in China especially, there is a Tai Chi exercise program which is helpful as a group therapy of Parkinsonism patients. They give a very good, they have various exercise specifically designed for Parkinsonism patient to avoid the freezing problems, the freezing gait disorders, and they have been proven to be beneficial for a population of patients which have Parkinsonism, advanced Parkinsonism. So with that, we complete our discussion on the gait and the balance disorders. We started off by discussing the various types of gait disorders, and then moved on to the various types of balance problems. What are the major players, and what can we do to reduce the risk of falls in these patients with a gait or a balance disorders? Thank you for watching sqadia.com. I'll see you in another lecture.